Hello friends, in continuation of the ENT sequence of lectures, in the previous class we are discussing about a very important disease which is an extension of acute suppurative otitis media, and this is called as chronic suppurative otitis media. So let me expand it first. Okay, so I will expand it. So the chronic suppurative otitis media is an extension of acute suppurative otitis media, but the difference lies in the fact that the tympanic membrane has got a permanent perforation. These are the tympanic membrane with permanent perforation. Let me change the point color option, and in color I will select red. Okay, so this is a typical endoscopic picture of a CSOM case. CSOM stands for chronic suppurative otitis media. So the word chronic is a long-standing recurrent discharging ear. Suppurative stands for a suppurative infection. Otitis media is for middle ear. So the typically the CSOM has got two categories. One is safe and one is unsafe. The word unsafe is used because of a presence of a unique identity in the middle ear, which makes the ear destructive and has got a property of dissemination or extension in the surrounding structure. The identity is called as cholesteatoma. So it is the cholesteatoma which makes the unsafe the ear unsafe. So the safe ear is a central perforation, and the cholesteatoma perforation is either a attic perforation or a marginal perforation. We have already gone through all the clinical picture endoscopic differences of a safe and an unsafe ear. So in the previous class, this is a this unsafe word is used because of a marginal perforation in the tympanic membrane or a attic retraction pocket. Along with these two clinical picture of the tympanic membrane, we also have got granulations and bleeding, which is present in some cases in case of a unsafe CSOM. This is a typical presentation of a prolapsed oral polyp in the ear polyp, which has origined itself from the middle ear mucosa, and majority of the cases the origin of this polyp is around the area of foot plate of the stapes. So it is highly advised not to avulse the polyp of the ear, because it may be arising from the area of foot plate, and ultimately you are going to dislocate the foot plate of the stapes and can have a iatrogenic labyrinthine fistula. So this is also a long-standing case of a unsafe CSOM. Look at, there is a difference, the destruction of the mastoid cortex through the mastoid antrum, and the cholesteatoma has extended into the antrum and then has distinctly destroyed the superficial part of the bone, the mastoid cortex area, and presents itself as a granulomatous growth. So nothing but a extension of a cholesteatoma from the middle ear to the mastoid antrum, and this cholesteatoma, by the presence of this proteolytic enzymes, can destroy the overlying bone and the soft tissue and present itself in the form of a fistula. This is called as a mastoid fistula. So these are all this is again an endoscopic picture of a central large perforation. You can see the handle of malleus, and this is anterior, inferior, superior, and posterior. So this is obviously will be the round window area, this will the eustachian tube area, and through this posterior part, this middle ear, this whole middle ear is continued through additus by a tube-like structure into a large, again a air-filled cell, which is called as mastoid antrum. Antrum is, again, if you can recollect, is a a large cell in a bone is called as an antrum, like a maxillary antrum. So in this unsafe type of CSOM, the cholesteatoma by gaining entrance through the attic part by a retraction pockets moves in the mastoid antrum, and it can destroy the roof and even the cochlear part, which has got a its presence in the form of promontory in the medial wall of the middle ear. So this is again, this whitish material is seems to be a cholesteatoma growth. This is inferior, this is superior, this will be posterior, and this will be the anterior. This is eustachian area, and this whitish tissue is nothing but a cholesteatoma. So this cholesteatoma has a property for destruction and makes the ear unsafe. This is a typical presentation of an unsafe ear. Look at this. This is the canal, and this is anterior wall of the canal. This is posterior wall of the canal, and this is superior part of the canal, and this is inferior part of the canal. This is the tympanic membrane. By and large, you can see that this patient has got a healthy tympanic membrane because you can appreciate the cone of light. But look at the attic. There is a huge expansion of the attic segment of the canal, and there is a bone erosion, bone destruction, with as well as you can say effacement. Effacement is a pushing of this canal wall along with the bone destruction, and this attic sac is filled with this whitish tissue, which is nothing but a cholesteatoma. So if this cholesteatoma gained its entry through the attic part, and this starts with a retraction of the tympanic membrane. So in the previous class also we already discussed, a deep retraction pocket is nothing but a future cholesteatoma. So this cholesteatoma is a desquamated squamous epithelium. So this pockets of and these nest of and this collection of a stratified squamous epithelium gained entry into the middle ear and then posteriorly into the mastoid antrum, and it's a very aggressive form of pathology. So this is again this is not a the retraction in this case is much higher, but this you can see again attic retraction, retraction. This is middle ear, handle of malleus, and you can see the prominent head of the malleus in this case. This is head of the malleus. So head of the malleus and this short process of the incus are present in the attic part of the middle ear, the superior part of the middle ear. It is not visible through the tympanic membrane. Through the tympanic membrane, you can only see the translucency of the long process of the incus and the stapes suprastructure as well as flute plate if the tympanic membrane is thin. Always you can have a look at the handle of the malleus. So this retraction pocket is not there is no collection of cholesteatoma still in this pocket. So this is quite a safe, you can say, retraction. And in order to determine whether it's going to be a safe or an unsafe ear, subsequently the patient has to visit the ENT surgeon office in order to check the progression of the disease in the sense is retraction pocket in this case. So this is again a very aggressive form of cholesteatoma. This I think this is very confusing, but this is a tympanic membrane, and this whole part of the pars flaccida has extended with the bone erosion and a bone expansion or effacement with a very angry looking granulomatous tissue in its bed. So this tissue is a granulomatous tissue which is always associated with a cholesteatoma case. So cholesteatoma, it has got desquamated squamous epithelium as well as very fragile capillaries which tends to bleed. So that's why that cholesteatoma has got a tendency to bleed. Apart from that, it also has got a loose fibrous tissue as well. So the tendency of bleeding and the granuloma formation is always associated with the presence of cholesteatoma in the middle ear. So this is again you can see this is superior, this is anterior, I guess, this is posterior, and this is inferior. So we have got a central perforation and a mild retraction, and this is a handle of the malleus. This is eustachian area, and this will be the mastoid antrum area. So this is again a variety of bacteria are present in case of a CSOM. Moreover, it's a, you can say, It's a mixed type of infection, and the tympanic membrane has got a permanent perforation and a recurrent discharging ear. The discharging of the ear in case of a CSM depends upon the status of the eustachian tube. If you have got a blocked eustachian tube, then the ear will behaves like a closed cavity, and there are no chance of ventilation. The only ventilation portal will be the perforation. So if the patient has got a large perforation, eventually this will also ventilates the ear, and the ventilation of the middle ear, as there will be diffusion of the oxygen from the surface of the mucosa, which will make the ear safe rather than being unsafe. So large size perforation is always good, or better than you can say a small size perforation, which will protect, which will have a more aggressive pathology underneath it, and the chances of ventilation is in case of a small perforation will be less. So these are the bacteria: Pseudomonas E. coli. Positive will be the Staphylococcus, and in case of anaerobes, which are frequently encountered in the case of a poorly ventilated ear. The middle ear just behaves like just like of a paranasal sinuses. If you have got a good ventilation through the eustachian tube, maybe the maxillary, frontal, ethmoidal, or a sphenoidal, then there is no problem. But as soon as the ostium or the opening of the paranasal sinuses are blocked, it behaves as is a closed cavity. There is a exudation, transudation, and subsequently it is formed by collection of pus. So likewise the middle ear behaves just like to the paranasal sinuses. So ventilation is the key. In case of paranasal sinus, the ventilation is done through the nasal cavity by via different ostia or opening, where in case of a middle ear, the ventilation is done by either by the eustachian tube in normal cases, and in case of a large perforation or small perforation of the tympanic membrane, the perforation will also act as a portal of ventilation. So these are bacteroidal. Bacteroides fragilis is the chief bacteria. So how can we radiologically do assessment of the middle ear? This conventional X-ray is rarely used nowadays because of the superimposition and the false positive, false negative, and there is superimposition of one structure of the another. So these are rarely used. The standard radiological choice to elaborate or elucidate the middle ear pathology nowadays is gold standard HRCT, or high resolution CT scan. You know, there are three types of CT scan: NCCT, that stands for non contrast CT scan, in which there is this is a plain CT scan, you can say. The second one is CECT, or contrast enhanced CT scan, in which we gave a radio opaque dye injectable in an injectable form, intravenous form, and this dye virtually or eventually enhance the tumors or any growth, and differently by the tumor itself. So the third one is HRCT, which is very fine sectioning, cutting in any of the axis, coronal, axial, or oblique axis. So this HRCT gives a perfect detailed three-dimensional picture of the middle ear. How is the status of this facial nerve? How is the destruction of Meliancus incus stapes going on? Is there a soft tissue growth in the middle ear in the form of cholesteatoma, which is blocking the editus segment? And how there is a roof of the middle ear is intact or not? So the every detail of the middle ear, if you can see, it can be clearly delineated with a high resolution CT scan, even to the extent of 1 mm. 1 mm. So 1 mm is very small, so you can section by section can have a great details of the middle ear, which helps in subsequent surgical part also. So you can assess how much the patient is having a hearing loss by a PTA or a pure tone audiometry. I've already detailed in the previous class. In case of a safe perforation, when there is no cholesteatoma, the chances of hearing loss are always of conductive type. Conductive apparatus is the apparatus which is present from the pinna up to the foot plate of the stapes. This is called as conductive apparatus. And next is a sensoroneural apparatus, which includes the internal ear and the propagation of the electrical impulse to the central nervous system. So in case of a safe CSOM, it always has got a conductive hearing loss. In case of a unsafe CSOM, when there is an extension of the disease or a cholesteatoma from middle ear to internal ear, it can destroy the internal ear, and hence the patient can have a sensoroneural or a mixed hearing loss. Mixed hearing loss in the sense is conductive plus sensoroneural both. So cholesteatoma by and large, apart from having some fulminative acute cases, you have to go through a surgical treatment in all of the cases. So these are what are the basics of this, the removal and the surgical process, surgical procedure which is done in a case of a unsafe CSOM with cholesteatoma is called as mastoidectomy. So the detailed segment of this surgical part we will discuss in the next class, and that will conclude after this surgical exploration of the middle ear through a mastoidectomy. We will conclude the CSOM segment. Then in the next class we will discuss about the complications of the CSOM, which is again very, very important. So thank you for having me. Thank you.